Dear colleagues and friends, ladies and gentlemen, my name is Nicolas van Mieghem from the Erasmus University Medical Center in Rotterdam, and on behalf of my co-directors, Kendra Grubb, Holger Thiele, Ajay Kurtenay and David Hildig-Smith, I welcome you to the second edition of TIO, the 100% online meeting on transcatheter cardiac interventions. And coming off a very successful first TIO meeting last year, including almost 10,000 participants over the 3 days, we now have already more than 13,000 registered physicians and caregivers, and the same superb faculty is returning for another 3 days, discussing hot topics in interventional cardiology, including live cases from 7 centers in Europe, UK and the United States. Every day we have again 2 main sessions of 2 hours, and new this year is the 1-hour break between these 2 sessions. We do appreciate our sponsors, so those are sponsored sessions. We have lined up 1 day on coronaries, 1 day with the keynote lectures and controversies. But without further ado, it is my great pleasure and honor to chair the first session of TIO2 on expanding TAVI indications, Dr. Roxana Miran, who is a multi-talented and phenomenal interventional cardiologist, but also director of the Center for Interventional Cardiovascular Research and Clinical Trials at Mount Sinai in New York. So TIO 2021, here we go.
Hello everyone and welcome to Transcatheter Cardiovascular Interventions 2021. We're so excited to be here, and this first session of TIO 2021 will be fantastic. We are very excited with our incredible panelists, as you saw introduced, and we're looking forward to 3 days of the most comprehensive live interventional meeting in the world that's taking place. Thank you, Dr. Van Mieghem, Professor Van Mieghem, for your incredible leadership in bringing this forward. Today, our first speaker will be Professor Van Mieghem, but let me introduce my incredible panelists: Professor Lars Sandergaard from Copenhagen, Professor Didier Cheche from Toulouse, and David Hildig-Smith from the UK. Welcome, all of you. Fantastic to have you all.
Thanks,
dear friends. Let's start with our first speaker, the director of this incredible course, Professor Van Mieghem. He's going to talk about moderate AS, the conundrum. Nicolas Van Mieghem, you're up.
Thank you very much, Roxana. So we're talking about expanding indications for TAVI or TAVR, and moderate aortic stenosis definitely is a conundrum that might be applicable for a TAVI procedure. These are my disclosures. And just to add some perspective, we all know that in the Western world, aortic sclerosis is quite prevalent in 1 of 4 of adult population, and 16% of those patients will progress to any kind of aortic stenosis. 4% of the patients with aortic stenosis also, or a quarter of the patients with aortic stenosis also have LV dysfunction. On the other hand, we all know that heart failure affects 4% of the entire population, and above the age of 70 years old, 15% of people have some kind of heart failure. And we know that heart failure is associated with a grim prognosis. So basically, as we age, there is a crossroads of 2 phenotypes of increased afterload. On the one hand, we have heart failure, predominantly heart failure with reduced ejection fraction, which is the leading cause of hospitalization. And on the other hand, there is aortic stenosis, that is the most frequent valvulopathy. So both have an increased afterload. For heart failure, it's quite clear. Guidelines strongly recommend afterload reducing agents. For aortic stenosis, the guidelines only recommend a treatment for the valve disease in case of severe aortic stenosis. So for moderate aortic stenosis, current guidelines typically endorse a watchful waiting approach. So there is some data from Australia that is of interest. They looked in over 240,000 echo studies with a follow-up of the patients of over 1,200 days. And you can see here in the middle of the graph that there are patients with mild aortic stenosis, moderate and severe. And the moderate aortic stenosis is the minority of all these patients. So there were only 3,300 patients with moderate aortic stenosis. And clearly this is, of course, a phase in transition between mild and severe. But what is quite striking is that these patients with moderate aortic stenosis have a high mortality rate. So you see a clear gradient, and you wonder whether it might make sense to treat aortic stenosis earlier in the disease cycle. So we looked then in 4 centers in Leiden, Rotterdam, New York, and Quebec at the fate of these patients with moderate aortic stenosis in combination with depressed LV function. The majority of these patients, and this is important, were mildly symptomatic. So more than 50% of the patients were in New York Heart Class 1 or 2, and still their cumulative major adverse event rate, and the adverse events were basically a composite of death, aortic valve replacement, or heart failure hospitalization, was 24% at 1 year, and then 10% or more each year thereafter. So basically the combination of poor ejection fraction and moderate aortic stenosis can be detrimental. Another study looked into predictors for a higher risk in patients with moderate aortic stenosis, and they tried to implement this paradigm of cardiac damage. And so there are several degrees of cardiac damage. It starts with LV hypertrophy and then goes to functional MR, the development of tricuspid regurgitation, and then RV failure. Well, if you proceed from stage A or 1 to stage 4, mortality will go up dramatically, but somehow this cardiac damage scoring system has not yet been validated for patients with moderate aortic stenosis. But this might be the way forward in the near future to identify which patient might qualify for an earlier valve replacement. I think when you talk about afterload, it is important also to understand the concept of valvulo-arterial impedance, which is basically the global load to the left ventricle. It is determined by an arterial component and also by a valvular component. And you see on the right-hand side of the illustration that patients with a high valvulo-arterial impedance in the majority of the cases have severe aortic stenosis. But in 1/4, there is moderate aortic stenosis. And this is important because if you look at the outcome, the survival of those patients at 5 or 6 years, then the survival is worst for the patients who had a medical treatment and had a high valvular arterial impedance. So this suggests that these patients have moderate aortic stenosis, because if they had severe aortic stenosis, they would have been treated. So basically, this is a hint that it makes sense to treat patients with a high valvular arterial impedance and to consider a treatment for their aortic stenosis. And this is basically illustrated in this graph. So the overall load to the ventricle is being determined by a valvular component and the arterial component. But as we age, we know that the elasticity of the arterial system goes down, and so the arteries become more resistant to vasodilators and other afterload reducing agents. So it becomes a fixed component, and only the valvular component becomes accessible for a treatment, and that could be the target for a transcatheter aortic valve replacement to reduce this overall burden to the ventricle. Can you do something with this ventricle when you replace the valve? I think yes, of course. This is data from the TOPAZ trial where they looked in patients with low flow, low gradient aortic stenosis, but basically they were deemed severe aortic stenosis, and then they did dobutamine stress echo not only to confirm the severity of aortic stenosis, but also to look for myocardial reserve. Well, regardless of the fact whether or not there was myocardial reserve, ejection fraction improved after the valve replacement, and the survival was the same for both groups. This basically was then the basis for the TAVR Unload trial. The TAVR Unload trial is a randomized trial currently ongoing, randomizing 300 patients with an ejection fraction below 50% and proven moderate aortic stenosis. Those patients are randomized to either optimal or optimized maximally tolerated heart failure therapy or the same therapy, but on top of that also a TAVI or TAVR procedure with a SAPIEN 3 and a SAPIEN 3 Ultra. This is an illustration that might also underscore the importance of replacing the valve for patients with moderate aortic stenosis and a depressed LV function. This is a case that has been included in the TAVR Unload, and we did a PV loop, an invasive pressure volume loop analysis. In red, you see the situation before the valve is replaced. After valve replacement, you see a clear shifting from the red to the blue. Basically, a clear signal of unloading of the ventricle, immediate unloading of the ventricle, but also you see that the end-systolic pressure-volume relationship so the red line becomes more steeper, meaning that the contractility almost immediately improved after the valve replacement. And on the right-hand side, you see the segmental desynchrony that is becoming more and more resynchronized after the valve replacement. And I think this is a pathophysiological argument in favor of replacing the moderate aortic valve with a new valve in patients with depressed LV function. So in conclusion, I think it's fair to say that moderate aortic stenosis is not trivial and may become a treatment target. Aortic valve replacement may reduce afterload and seems particularly of interest in patients with depressed ejection fraction. Pressure volume loop analysis suggests immediate improvement in contractility, loading conditions, and improves also synchronization of the ventricle. And the TAVR Unload trial now is really gaining momentum also in the United States, and we almost reached 50% of the inclusions. Thank you for your attention. The floor is back to Roxana.
Fantastic talk. I mean, really, truly an area that we will be focusing a lot on. But before we go to our discussion, Nicholas, I want to put up the question that I want everyone on our live poll to answer to. How would you approach a patient with severe aortic stenosis, but asymptomatic over the age of 65 years? Please vote. We really want you to think about this. SAVR, TAVI or TAVR, or watchful waiting, no intervention. Please vote. And as you're all voting, let's go to our wonderful panelists. Thank you all for being here. So this conundrum of moderate aortic stenosis, Didier, what do you think? Is this the next target?
Yeah, I truly believe that this is a major topic because this is a situation that we regularly see in our heart valve clinics, and it's always difficult to determine the best strategy for this type of patient. So we need the tools to properly re-stratify these patients, and I'm really looking forward for the unload TAVI trial to see the results and to see how we can best improve our the quality of the care for these patients. So I have to say that it really depends. It's a case-by-case discussion, and it really depends on the patient, the age of the patient, the amount of the symptoms, the presence or absence of symptoms, the potential presence of over comorbidities, over interventions, heart valve interventions required. And for example, if we have something to do on the mitral side, and we have a kind of doubt on the severity of the AS, the LVEF is really depressed, sometimes we treat this patient because we have the gut feeling that this is going to be beneficial for the patient. But we need evidence, and we have to congratulate Nicolas for leading this superb trial.
No, it's really a fascinating area, because I think that it's bringing us more and more into the hemodynamics and where we're going with the pressure volume curves that Nicolas showed us is really very, very telling. David, do we know how to do this and how to diagnose this, and in what way would you proceed to look at moderate AS, and how are you approaching these patients?
No, it's a good question, Roxana. And I mean, I'm very interested in this area because Nicolas presented the science and also showed our limitations in how we can assess this and check how we should be approaching it. But interestingly, if I could present the anecdote, which is to go with Nicolas's science, certainly in our institution, we look at anyone who can generate 3 meters per second and more. And if they're symptomatic and they're otherwise a good candidate, we wouldn't disbar them from having TAVI simply because they haven't reached the severe threshold. We would definitely consider it. And equally, when we get patients who have poor left ventricular function but can't even quite generate 3 meters per second, that's pretty much a cutoff for us, saying, well, the ventricle is actually too poor and the aortic stenosis is not so significant. So we use that quite often as a relative cutoff point, and that fits with what they're examining in unload TAVI. And I think the study as set up will be strongly positive for TAVI.
Lars, what are your points in this? What should we take away from this important talk?
I mean, this question is certainly very important, and this trial is going to give us the first insight in this. I would say we're going to treat patient with a procedure which potentially have risks. So I assume that they're only going to take patient which hopefully can be treated safely, good transfemoral access, no risk of coronary occlusion, no bicuspid aortic valve, and so on. And also we have to make sure that we are not going to harm the patient by the procedure. I mean, if patient have a new conductance abnormality, new onset left bundle branch block, or even a permanent pacemaker, that may also be devastating in a patient who already is in heart failure. More than mild PVL can also impact the outcome. If the patient have longer life expectancy, we also have to consider what about the durability of these valves and the possibility for revalving the patient. What about access to the coronaries down the line? So I think it's a very, very complex question to answer. And I really look forward to see the outcome for this trial.
No, I mean, I think, Lars, you really put it out there. And I would have to say that we really have to kind of take the risks and benefits. Nicolas, I'll come back to you now. Who would you not treat with moderate aortic stenosis?
Yeah, that's of course important, because not every moderate stenosis, every moderate aortic stenosis needs treatment. I think for instance, when we do our workup, all the patients mandatory get a CT scan to evaluate aortic root calcification, because we are indeed talking about moderate stenosis, so there expectedly might be less calcium, and we all rely on calcium to anchor our valves. As a matter of fact, Lars will talk later on aortic regurgitation, and those are situations where there is hardly any calcium in the aortic root, and that poses very specific issues with TAVI. The same thing counts for moderate aortic stenosis. So basically, when there is hardly any calcium, those are not the proper patients for an early valve replacement, and I would then recommend to wait for this valve to become more stenotic, develop more calcium, and then undergo a safe valve replacement. important aspects of the TAVR Unload trial are also, and this is in line basically what David suggested and also what Didier mentioned, all the patients are being evaluated by a screening committee. And the screening committee then will determine whether first this patient actually does have moderate aortic stenosis and it's not severe or mild. The LV function needs to be depressed, but also from a technical point of view, a safe TAVI is possible. There's a high likelihood for a safe TAVI because we have to bear in mind that we are so familiar with a high operative risk. But in this day and age, you can also talk about a high risk for a TAVI, right? And so in this kind of trials, you have to be very careful that you not expose patients to a high-risk TAVI procedure.
No, it's really fantastic points and a great, great discussion. Can we see the results of our poll? Is that going to come up? Can we see that? Because I'd love for everyone to sort of just quickly comment on that. All right, great. Well, as the poll is coming up, and I know that you have a great case for us, Nicholas, coming up really soon, and you're going to leave us to prepare for the case, and we're going to go off to Professor Cheche, who's gonna give us his next lecture. Any really important, valuable tips that we could give for this severe aortic stenosis who's asymptomatic? Lars, what are your what's your approach before the poll comes up?
I would say, let's say the patient is an elderly patient, a typical patient we're treating today, 80 years of age. You have to consider whether the potential benefit of revalving early is going to change anything for the patient. The patient may actually die from other factors before he gets symptomatic from the aortic stenosis. If you're treating a patient who's much younger, where early intervention may improve the LV function in the long term, you have to consider whether the durability of this valve is going to be an issue. Let's say you're going to intervene 10 years earlier than otherwise. Is valve failure down the line and revalving also going to be an issue? So again, I think it's a very complex question.
Well, you know, the poll is not ready yet, so it's going to be ready right after Didier finishes. So we're going to go to Didier Cheche. Thank you, Nicholas. We can't wait to see you in the live case. So looking forward to the live case, which I'm sure will be lots of good discussion around that. And with that, we're going to talk about asymptomatic severe aortic stenosis by Didier Cheche. Thank you.
Okay, thank you, Roxana, for this very nice introduction. So let's talk about asymptomatic severe aortic stenosis and see what are going to be the results of the poll. So here are my disclosure. So a little bit of background, but everybody knows that aortic stenosis is a quite frequent valvular disease in the general population, that it's associated to more than 50% of mortality at 2 years when the symptoms occur. Surgery and TAVI are the gold standard contemporary practice, and as they are discussed in every heart team setup. But we need to find out and we to understand more about asymptomatic severe AS, because this is truly a subgroup of patients that is really difficult to assess, really difficult to re-stratify, and we need to find out what is the best treatment. So there is a lack of evidence for asymptomatic severe AS patients. So why is it important to identify this subgroup of patients? Because you can see that when these patients are matched to a general population, the asymptomatic severe AS patients have a decreased mortality, a decreased survival during the follow-up. So it's really important to identify these patients and to understand their pathology and to determine the need, the potential need for a aortic valve replacement. So how do we risk stratify this patient? The first thing is to really make sure that the patient is asymptomatic aortic stenosis patient, and apart from the regular items that we have, the aortic valve area, less than 0.6 centimeters square per meter square. The Vmax, the peak velocity, is quite important. And when the patient reaches 5 meters per second, he is considered to be at a very severe AS patient. There is also the mean gradient. Above 40, this is the regular cutoff, but above 60 millimeters of mercury, this is a very severe aortic stenosis patient, and that patient has to be asymptomatic. So, but how do we make sure that the patient is asymptomatic? The guidelines are not really clear about that, but we may use exercise testing to reveal these symptoms, because you can see that the patients for whom symptoms occur during the exercise testing have a decreased survival during follow-up. So it's really important to make sure that the patients are truly asymptomatic. Otherwise, we have to reclassify them as symptomatic severe AS patients and offer the best strategy, whether it be surgery or TAVI, according to the profile of the patient. So how do we risk stratify this severe AS patient? The first thing is to look at the valve. Looking at the valve starts with the calcium, and when the calcium load is moderate to severe, the survival is impacted. So this is a very simple way to assess that. Look at the calcium burden. The other thing is to have a look at the LVEF, and the general cutoff that is accepted is 50%, and this is associated to an increased mortality. But we have new data coming from the AVEC registry, the Heart Valve Clinics registry, that followed up longitudinally asymptomatic severe AS patients. And it's likely that the threshold of 60% of LVEF, below 60% rather than 50, the impact on survival appear for this asymptomatic AS patient. Quite modern way to assess LV dysfunction, because 60% can be considered as a normal LVEF, but this could be associated with early signals of systolic dysfunction, and this is the global longitudinal strain that is appreciated by the echo. And 1/3 of the AS patients have these early signals of depressed LV function, systolic function with the global longitudinal strain. So this is a kind of example. You have a patient during the follow-up who has an increase in the left ventricular hypertrophy, an increase in the gradient. The LVEF remains more or less the same, but the GLS, the longitudinal strain, decreases, and this can be helpful to early identify this patient and offer the best strategy according to the patient. In terms of cutoff, there are a couple of studies. These are small studies, but in this study, less than 18% of GLS is associated with an increased mortality. That cutoff was 14.7% in these other studies. So this is a rough estimation of what we can take in terms of GLS cutoff to risk assess these asymptomatic patients. So another important thing is to try to understand what is the amount of fibrosis that the AS provides to generates at the level of the ventricle, and this is evaluated by CMRO, and it's associated with a decreased survival. So we see that we have a quite significant number of factors that can be evaluated with more or less complex methods, but this CMR with the fibrosis seems to be a very promising tool to assess to risk stratify our severe AS patients. So if we come back to tools that are more simple usable in daily practice. The BNP level has been proposed, and the threshold is most of the time 100 microgram per milliliter. But something that we may utilize when we consider the BNP is the ratio. If we have a BNP ratio in regards to the normal value over 3, this is associated to a clearly impaired survival during a long-term follow-up for asymptomatic AS patients. So this is a simple tool that we can utilize. So Nicolas has presented the cardiac damage staging, and this in the partner 2 trial was associated in these intermediate risk symptomatic patients to a gradual increase in mortality of this patient. When we applied the same classification, cardiac damage classification, to asymptomatic AS patient, we observed the same pattern. The more advanced is the damage, the cardiac damage, the poorer is the survival for the patient. So we need to understand this classification that we all know now, and this is something that we may utilize to re-stratify once again our severe AS patients. Just a couple of words on the guidelines, just to tell us that the guidelines are really quite small, because the number of studies that really studied this patient is really small. And you see that the level 1C guidelines refer to the LVEF below 50%, or for the ESC, CTS guidelines, a patient with symptoms that occur during stress exercising. For the American guidelines, the CCHA guidelines, it's exactly the same. LVEF below 50%, it's a class 1 recommendation, level B, or a patient that requires another surgery with a severe AS can be operated without symptoms. So this is the level of recommendation that we have from the guidelines. So briefly, before concluding, a couple of studies, and this is a small study, but that was published last year, that recovery study that compared the surgery, early surgery, to a watchful waiting in a cohort of extremely severe asymptomatic AS. You can see the level of Vmax and a mean gradient. And clearly, that study promotes early surgery for these patients. We can see, we will see in the future if TAVI does the same. But you can see the difference in terms of mortality at 8 years, whether the patients are early operated on or underweight and conservative management. The mortality reaches at 6 to 20% at 4 to 8 years, as compared to 1% when they undergo surgery. So this is very important. Confirming that meta-analysis, it seems that when we operate early these patients, the survival is preserved, and regardless of the level of the LVEF. So just briefly to conclude, I like that slide that kind of summarizes how we can best, in a contemporary way, manage these severe AS patients. The first thing is to try to assess the LVEF. If it's below 50%, the guidelines recommend to go for an early treatment, whether it be surgery or TAVI. We will have to wait for the results from the early TAVR trial or the evolved one. If the patient has a abnormal stress exercise testing, this is another indication for surgery. If not, we'll need to implement all these new elements that we have, whether it be the BNP level, the troponin level, the degree of fibrosis, the level of longitudinal strain. And so it's really an integrative approach to try to stratify the risk, the spontaneous risk of a patient who has a severe AS without symptoms. We will have to wait for the future for this major randomized trial, the early TAVR trial and the evolved trial. And we hope that in the future we'll get a better understanding of how to treat and to manage these patients. Thank you.
Thank you, Didier. That was a fantastic overview of asymptomatic aortic stenosis. And I think after looking at that algorithm for your conclusive slides, it really does give you a very, very good feel that this could be a way to go, and following those instructions does give you some understanding that's not all asymptomatic patients should be left alone. Severe asymptomatic aortic stenosis, I think, is a fascinating area. Let's see how our audience responded to evaluating and how to take care of these patients. Can we see the poll, please? So how would you approach asymptomatic severe aortic stenosis in patients over the age of 65? Most of the people are telling us TAVR. Also SAVR. Watchful waiting, no TAVR, is second after TAVI. So interesting. So there are people who are leaving this on a watchful waiting. Let's go back to our panelists. David, what do you think about that? The result of our poll.
I think we've got some inclusion bias in terms of who's watching and who's making those decisions. Of course, the question of what this patient should have is not something that can be answered like this. It depends on so many other factors. Depends on the anatomy, the calcification, etc., etc. So I think in most places it's true to say that initially a patient presenting like that will probably have watchful waiting in reality. Otherwise, surgery is a perfectly reasonable option. Patients age 65 often have valvular abnormalities, might have a bicuspid valve, they might have severe LVOT calcification. So on a simple question like that, you can't just simply suggest that they have a TAVI. You, of course, have to have a great deal more information to decide.
No, you make a great point. I mean, I think one of the things that I really like about that new classification is seeing that the patients, a good majority of the patients with asymptomatic aortic stenosis fall into those early stages, and that those stages, especially even stage 2, and it's giving you there is an important mortality benefit and reduction in mortality even in those patients. Lars, what's your approach, and in what way are you evaluating this? Because it certainly is not a slam dunk. Are you using biomarkers? Are you exercising these patients? What's your approach?
I mean, it's always important to find out whether this asymptomatic patient is actually symptomatic. So, I mean, use exercise to see whether you can demask symptoms in these patients. But if the patient has a severe aortic stenosis and is truly asymptomatic, as I said before, I think it's a complex question to answer whether you should re-intervene early on. Again, if the patient is very old, you may take a risk without the patient would ever be affected by aortic stenosis because the patient may die for other reasons. And on the other hand, if the patient is very young, you have to consider whether potential complications to a TAVI procedure will also impact the benefit of early revalving. Once again, PVL, conductance abnormality, possibility to access the coronary arteries, what's going to happen when the valve is going to fail and we need to revalve the patient. So again, I think it's to answer this question, we really need to talk about lifetime management for these patients and not only about the short-term what we gain in the short term.
No, I mean, I think you make a very, very important point. Yes, go ahead, David.
No, well, I was going to say, I mean, I think the topic is really interesting, but you have to ask yourself with the patient, why are they saying they're asymptomatic? Is it because they're scared of having something done, which is often the case, and you then have to try and tease out of them, well, can you actually do what you did this time last year? And the other really important thing for me with asymptomatic patients is, in the end, you and they have to come to a negotiated agreement. It's no good us just saying somebody has no symptoms, you must have open heart surgery, or you must have a They're never going to agree to it. It's a negotiated compromise. So very commonly, the real medicine here is not, I mean, Didier's presentation was absolutely fantastic and shows us loads of indicators by which we can hint to the patient that they need something. But in the end, the patient has got to come to the point where they realize and understand and accept that they've got to have something done. Otherwise, you get into real trouble if you try and coerce people into having something that they don't really feel they need because they haven't declared any symptoms. And that's, for me, where all the difficulty lies with the asymptomatic patients.
No, I mean, I think very important point. But let me ask you, because Lars put out a really, really good point, the lifetime management of a patient with aortic stenosis. If that asymptomatic patient is 45 years old with a bicuspid valve, what are you doing? Didier.
Well,
Yeah, it's really a coincidence, a nice coincidence, because I had the same patient. So I had discussed with this patient last week. He's more or less my age, so I'm not going to give you my age, but you can guess. And he was operated. He had the bioprosthesis 10 years ago because he wanted to be active and so on without any medication. And now the bioprosthesis is demonstrating increasing gradients, but the patient is still asymptomatic. So I had to discuss with him and to through a serial assessment with various TTEs and discussing with him all the parameters, he spontaneously understood that these early signals were not favorable, and it's probably better for him to undergo another surgery without symptoms and to get a mechanical valve at that stage. So I do believe that EDEV is really straight to the point. We need to include the patients and to make them understand that they need something. Despite the fact that they are asymptomatic, the disease is progressing and they need something. So discussion of the patient, trying to unmask the symptoms through exercise testing, and sometimes with all these markers of risk, spontaneous risk of the aortic stenosis. This is an integrated approach, but the patients remain central. I like to discuss with the patient.
Wonderful. Well, thank you so much. What a fantastic discussion. David, I know you're going off for your live case, and we're very excited to see you. I know you're going to have a fantastic case for us with Accurate Neo, I think. I don't want to give it all away, but we'll see how that goes. And it really is my pleasure and an honor to present Lars Sundergaard from Copenhagen. He's going to talk to us about a very important topic, a new topic, the approach to aortic regurgitation, pure aortic regurgitation. Is there a transcatheter approach? Lars Sundergaard.
Thank you, Roxana, for this introduction. So I'm going to talk about TAVI in patients with pure aortic regurgitation. And most of these patients have no calcium in the aortic annulus, and that's why it's becoming much more challenging to treat these patients. These are my potential conflict of interest. So let me just show this survey here, which was done by my colleague Ole de Backer a few years ago, so only 3 years ago. And you can see that among 12,000 patients undergoing TAVI, only around 150 patients actually was treated due to pure aortic regurgitation. So it's only about 1% of the patients undergoing TAVI which have it due to pure aortic regurgitation. If you look into the literature, there should be about 10% of the patients suffering from aortic valve disease which should have regurgitation. So this number, of course, also represents that TAVI operators are very reluctant to take these patients on board because the high risk of an suboptimal outcome. The reason for a patient having a pure aortic regurgitation is, going forward here, is often that the valve is degenerated. This is about 2/3 of the patient. The rest of the patients is because of aortic aneurysm, dilatation of the aorta, vasculitis, arteritis, after endocarditis, and also after chest radiation therapy against the chest. So it's a bit slow here. So let's start with a case. This was a case we had just a few years ago. An elderly gentleman, 83 years of age, had a degenerative aortic regurgitation. He was discussed at the heart team, and due to high surgical risk, he was offered to have TAVI. And as part of the workup, he of course had a CT scan, and the CT scan showed that he had very little calcium in this tricuspid aortic valve. For the time being, there's no dedicated valve for these patients. So we have used in a number of patients the accredited neo valve. The reason is that it got this upper crown, which potentially can anchor on the leaflet, and we have done that in a number of patients with very good outcome. So this patient was treated, as I said, with the accredited valve. I have tried to show where the aortic annulus is. So it was a normal implantation, aiming for the normal position of the valve during release. You know, this valve is a top-down deployment. So first the upper crown was deployed, and then the lower part of the valve was deployed. So what happened after deployment of the lower part here, if I can make it move forward, doesn't really react, is that you can see that, sorry, it's a bit slow. I'm afraid it doesn't work this. So you see here, this is the final deployment of the valve. The valve is sitting for a few seconds in the aortic annulus and then is embolizing into the left ventricle. And the valve is always embolized to the left ventricle because as the leaflets are closing, you have the diastolic pressure in the aorta, which is pushing the valve towards the LV. So in this case, we did what most sites will do if you have an embolized valve. We implant a second valve inside, in this case, a Sapien 3 valve, and we had a nice outcome. So just to show here some of the data on this, this is a study we did ourselves from Copenhagen, this survey. You can see that with the first generation biprosthesis, it was about 1/4 of the patient who need a second valve, which has been less with the newer generation where you have possibility for recapturing. It's somewhere between 2 and 5%. And also quite a significant number of patients have severe, moderate aortic regurgitation after this valve. And this was also found in this study from Raj Makar, who's led this, that a very high number of patients need a second valve, which has been better with the second generation valve, but there's still also quite a few patients who have a significant aortic regurgitation afterwards. And also if you look at the 30 days mortality, despite it's a little bit lower with the second generation, it's still around 10%, which I think in current area is a very high number for doing a TAVI procedure. It also depends on what kind of valve you're using. The valve people think is the most dedicated is the Jena valve, and you can see if you use the Jena valve, you have a lower rate of paravalvular leak that compared to the Evolut platform, and particularly for the old core valve platform. You can see that patients who have some degree of calcification in the aorta often need less a second valve. So those patients can often be treated just with one valve, but there's still a chance that you will need a second valve. It's been discussed whether oversizing is the way to come forward, and I think it depends on what kind of TAVI platform you use. So let's say that you use an Evolut platform, which quite a few sites will use as the first one. I think if you're too aggressive of oversizing, this tapered configuration of the inflow part of the stent frame will actually pull the valve towards the left ventricle. So oversizing may be associated with a poor outcome here with a higher rate of embolization towards the LV. If you have a more cylindric stent frame, in those cases, oversizing will probably be safe without risking embolization to the LV. Medtronic use, when they acquired the core valve platform years back. They also acquired the Engager valve, which was actually anchored by on the leaflet of the native aortic valve, but they gave up this program. But I think this is something we need to, or the companies need to go back to if we want to treat these patients. And I think the only valve for the time being which is using this concept is the Jena valve, which, as I understand it, has been under investigation in the US now, both for patients with aortic stenosis, but also for patients with aortic regurgitation. So in this case, you open up these three anchors, you orientate the valve inside the aortic anus to have commissural alignment, and then use these anchors to fix the valve on the leaflets. So here, just to conclude, today, aortic regurgitation, pure aortic regurgitation, is only accounting for about 1% of the patient undergoing TAVI, probably because quite a few of these patients is declined. Most of these patients have no or only mild calcification in the aortic valve, and that also means that it's a very slippery landing zone and the valve tends to embolize towards the left ventricle with the need for a second valve. Post-procedural paravalvular leak is common. Anchoring by oversizing more than according to the IFU can be a problem, particularly if you use stent frame which got a tapered configuration. And I think if you want to engage on this patient population with pure aortic regurgitation with no calcification in the aortic anus, we need new and dedicated transcatheter heart valve designs. Thank you.
Thank you, Lars. What a fascinating area of discussion, pure aortic regurgitation. From your talk, my feeling is we're not ready for prime time here. Am I right?
I mean, again, there should be about 10% of all aortic valve disease patients who suffer from aortic regurgitation. We're only treating about 1%. So I think everyone is very reluctant to take these patients on board. So I think the patient we actually treat is the patient who have simply no other options. A patient who's very symptomatic due to the aortic regurgitation and where the surgeon refused to operate on them. Those are the patients who currently have a chance to undergo TAVI.
Yeah, I mean, I find it's a difficult area, I think, in aortic regurgitation. And the pitfalls, you pointed them out really, really nicely. Didier, what do you think is the future? Do we need new stent designs here? Is this about the stent design, or are we waiting too long, for example, on some of these AR patients where there's a lot of dilatation, as you know, as time goes on? With aortic regurgitation, there's a lot of waiting before we even send these patients for surgical replacement. We hope to help them out, and they're mostly, a lot of them are asymptomatic, they're younger, they have other aortic aortopathies. This is a difficult part, but if you come to a TAVR, if it should be 10%, as Lars says, do we need new stent designs? Stent valve designs?
I think it's a key question, Roxana, and you're perfectly right. I do believe first, like your comment, we're not ready for prime time yet, and despite all the experience gathered with extensive TAVI programs, we still don't know who is a typical and perfect candidate for TAVI in the context of pure aortic regurgitation. There is still that uncertainty about how much of a sizing do I need, what anatomical criteria am I looking at to make sure that the valve is going to anchor and to stay in place. And I do believe that the LVOT, as Lars has demonstrated through his case observation, is really important. The shape of the LVOT and the amount of sizing that we're going to apply at the level of the LVOT may help in sealing and securing the anchoring of the valve. In the future, I believe that we need specific designs for pure aortic regurgitation, and I like the valves that really respect the anatomy of the patient. Apart from the commissural alignment, we make sure that we grab the leaflets and the device remains in place, and with a proper sizing, we may have an appropriate anchoring. Are we operating too late on these patients? I believe yes. It's the same issue as for asymptomatic AS patients. Most of these pure aortic regurgitation patients are asymptomatic for a long period of time. So we need to find out what are the if there are additional criteria apart from the LV dimensions and the LV, the systolic function during follow-up that we may assess to early understand that there is a failure and we need to operate on these patients. At last, as we are talking about TAVI, this relates to high-risk patients, and it's always difficult because we know that these are riskier procedures than for aortic stenosis. So there is a potential risk for a need for operation of these patients. So I think it's really important to discuss within the heart team to make sure that if the patient experiences a bad outcome, procedural complication, there is still the door is still open, the window is still open for surgery. So it's really a complex group of patients. We need dedicated devices for that. We need data because the level of data that we have is not enough, and we need to all together understand how to size and how to treat these patients.
Thank you. That was great. Lars, you probably have the most experience in this. Take us through how you evaluate patients with pure aortic regurgitation and what you do in your center.
Yeah, as always, we discuss these patients at the heart team, and where a patient with aortic stenosis, the bar from accepting the patient for TAVI has declined. So we used to treat high-risk patients. Now we're treating even low-risk patients if they're over a certain age. For these patients, they have a CT scan, and we look very careful on the size of the aortic annulus, and also if there's no calcium. If there's no calcium, we discuss with the surgeons and try to take this, try to make them offer surgery despite the patient is at a high surgical risk. So the bar is very high to accept them for TAVI. The patient we accept for TAVI, we have a very detailed discussion with the patient about the risk of it, that there is a risk that the valve may embolize, that we need a second valve, and also we had cases where the valve which was embolizing into the LV actually damaged the mitral apparatus. So it's certainly not a benign thing just to leave two valves into it. But some of the patients accept it because they're very symptomatic, and luckily most of the patients have a good outcome. But again, the data we see on second valve and paravalvular leak and mortality is much higher than we would normally accept for patients undergoing TAVI for aortic stenosis.
We have just about 1 minute, and I can't stop by not asking you, for all of your TAVR patients, just quickly, what's your anticoagulation, antiplatelet regimen? I'll start with you, Didier, then to Lars, and then we go to Brighton.
Okay, so to make it short, aspirin for everyone, unless there is atrial fibrillation, for which it's going to be warfarin or NOAC for lifetime.
Yeah, we have the same. It's monotherapy. Sorry.
Yeah.
Go ahead, Lars. You tell us, and I just want to know when.
We only use monotherapy if the patient have no indication for anticoagulation. It's only aspirin. If there's no coronary artery disease or something else was dictating a dual antiplatelet therapy. If the patient have atrial fibrillation, it's only anticoagulation, no antiplatelet therapy on the top of it. And this is based on the data we've seen from the Galileo trial and the Popular trial. In these elderly patients we currently are treating, it seems that less is actually better.
Wonderful. Well, thank you both. It's nice to hear that less is more in these patients for now, is what you're saying, and I think we're moving in that direction. It's a popular choice, isn't it, based on the popular the popular studies. Let's go to Brighton.